I wanted to just take a moment, talk from an organizational standpoint about two people that we lost this year. David Woodmansey not only co-led at our policy action group, task group. For those of you who had the pleasure, joy in your life of knowing David, he was just one of those positive people who everyone who had the chance to interact with David felt enriched, felt uplifted. He was somebody who believed that change was possible and helped to make it happen. And his loss affected all of us at the American Cancer Society, and particularly at the American Cancer Society Cancer Action Network, quite profoundly. And we're deeply appreciative for just one of so many roles that he played, and died at a very young age of his own cancer diagnosis at 58. So we just want to honor David and his family and thank him for his work. The loss of Tom Weber really affected us deeply. You know, great organizations have stable leadership. They have continuity. And in, you know, as Bob said, hard to believe, our 23rd meeting, and we've had 3 chairs in that time. It's only partially because they renominate you without asking. That's only part of it. We do have free will, those of us who've been honored to serve in this role. But Tom, you know, when I think about this campaign we just finished, 80 by 18, let me assure everyone there would have been no 80 by 18 without Tom setting the stage for doing that. And those of us who served with Tom on the steering committee remember one of his biggest pushes was we have to be national. We have to reach out across the nation. We're too, you know, our meetings are always in Washington. We have a Washington focus. And as Bob said, that's why he set up in part our visits where we went across the country and learned from others. But Tom really believed in big goals, in getting important things done. And perhaps in no area, and we'll hear more about this at this meeting, did he contribute more than in his work in highlighting the fact that the epidemiology of cancer, of colorectal cancer, was changing, and that the risk was increasing in younger adults, and his leadership in our early onset colorectal cancer task group, and frankly for the whole nation through his own work in New York, will leave a remarkable legacy. So we're really very touched and so honored that Tom was such an important part of our lives, but the corollary of that is that his loss is particularly felt. So for all of these individuals who we've lost, and so many more whose pictures are not here, which are the reasons why we are here, let us celebrate their lives, mourn their loss, and share just a brief moment of silence together. Thanks, everybody. All right, I'm going to take a deep breath. Turn our attention to 80% in every community. This is different, and we believe it is. But let's start talking about national progress towards 80%. So the 80% by 2018 campaign, I believe, was one of the most effective screening campaigns in history, and it had a transformative effect on the colorectal cancer burden in the United States. But the reality is, as we said last year, the campaign is over, and we recognized that at last year's meeting, but we did not have our final report. We did not have 2018 data, and now we do. So, ladies and gentlemen, here is our final report card for 80 by 18. Here's the data we had when we last met. BRFS, and we'd agreed from the start that we would use BRFSS data as kind of our ultimate report card. And believe me, given how hard we all work, we hold our breath when we know these data are coming out. And we had the largest 2-year increase, 1.5% additional increase, and we hit 68.8% for our national screening rate. as Janaba, where's Janaba sitting in the back? And Janaba, of course, we bug her like, hourly? It's not too bad while we're waiting. Data out yet? So she's so nice about it. She never gets mad at us. But as Janaba said to me, she says, believe me, Rich, these are amazing numbers. Moving BRFS at all is extremely difficult. So anybody want to take a look at how many more people are up to date with screening as a result of your work and our work? 9.3 million more people. One of the things we should be proudest of is the work we've all done in the federally qualified health centers. Since 2012, when they first started measuring, a 14% increase in screening rates in the FQHCs. So huge shout out to all of you who have worked so hard with our low-income and uninsured patients. The data for people 65 to 75 is absolutely remarkable, and our Medicare commercial plans have absolutely knocked it out of the park. 105 plans who topped the 80% goal. Look at the data by race and by ethnicity, by national background, and the numbers improved in every group. This is just 2016 to 2018, but I want to and you see one of the things that, remember we've celebrated in New York City how they largely eliminated the white-black disparity, and in 80 by 18, we didn't completely eliminate that white-black disparity, but we came pretty close, and that's fantastic. I can tell you, if you go back to 2012, even the other multiracial went up over that period. It went down in this 2-year period. But I want to particularly shout out, how many of you do work with American Indian Alaska Native population? So since 2012, a 9% increase in colorectal cancer screening in American Indian Alaska Native populations. Really one of the most remarkable accomplishments of the whole thing. Increasing screening in the Hispanic group, Latinx group, one of our most difficult challenges, still have a lot of work to do, but these are impressive numbers. We really were true in our efforts to try to eliminate disparities. If you look by education, this is really where you start to see the emergence of major disparities. If you look at people who are college graduates, 75.6%, that's across all age groups, and you'll see more data about this later. 65 and over, very interesting, much higher. But as educational achievement goes down, really hard to move those rates. And for those people less than high school graduates, at least in this 2-year period, no budge and a much, much lower rate. Same thing for income. We did a great job in these 2 years with increasing screening rates in the lowest income group, a 3% increase, but still enormous gaps between those who earn over $75,000 a year, which in today's world isn't being super wealthy, but it just shows you that that increment of wealth makes a huge difference this is annual income, it's not wealth, it's annual income. Total wealth is a different measure than that, but a big source of disparity. If you have health insurance, we had a good 2 years, but look at the rates. We did improve screening rates since 2012 for those without health insurance, but not in these 2-year period, and not surprisingly, this is probably the single toughest group to reach, is those without health insurance. So I know what you're thinking. I know this group. You're thinking he's hiding something. He only showed us BRFSS. We all know that, no, there are a lot of people here who do BRFSS, but there are people who say, well, NHIS, doesn't overestimate. It overestimates a little less than BRFSS. BRFSS tends to overestimate a little bit. I'll bet you he's not showing us the NHIS data because it didn't really improve much at all. Guess again, and we just got the NHIS data, and from 2015, remember we had that plateau, 2010 to 2013, before we launched the campaign, 3.5% increase in rates just between 2015 and 2018 as a result in the NHIS data, and Stacy Fedowa will be presenting much more from the NHIS data later in the meeting. But No question about it. And interestingly, not much difference in national rates achieved. It's about 67% in the NHIS data. So, really a good match and very confirmatory. Here they are, 67 to 67% that we achieved in 2018. So this does not happen without amazing work, of course. I want to share just the stories of last year's grand prize and National Achievement Awards. Our grand prize winner was Noella Community Health Center in New Orleans, who implemented numerous evidence-based system changes to increase colorectal cancer screening. How about this for an improvement rate? If anybody can top this one, gang, you come find me. 3% in 2012 to over 80% in 2018. Keith told me it was easy, anybody could do it. All right, he didn't say that, but you will be hearing more from him. Fantastic. AT&T employs thousands and thousands of people, and a lot of them are kind of working class people who are out, in the field, driving, doing all sorts of things, and they partnered with ACS to promote screening to their U.S.-based employees, and they increased colorectal cancer screening by 8 percentage points across the whole company. This is the kind of model we need for corporations to really be a partner of ours. We met Brian Green, I think, just last year at this meeting. Others had met him before. He's our physician champion honoree for 2019. He provides free screening colonoscopies to uninsured and medically underserved South Carolinians, and he recruits other gastroenterologists to donate care, lobby state legislators for program funding, a real role model for what is necessary to bridge the gap, particularly for those who are uninsured. So Brian, I trust, is here somewhere. Is Brian? No. Well, you have to tell him we showed his picture. So one of, Kaiser Permanente of Northern California has been a champion of champions. It was one of the site visits that Tom Weber took us on years back. They've achieved screening rates over 80% since 2011 using amazing outreach to their 4.3 million members. And why are we doing this? It's great to get the screening rates up, but how about a 52% reduction in colorectal cancer deaths in the work in Kaiser Permanente? Where are the Kentuckians in the room? Kentucky never talks about what they've done in colorectal, but we're here to shout out. No. Fantastic work in Kentucky. 70-plus organizations, over 450 partners, established a statewide screening program for the uninsured. And by 2016, screening rates rose to 70%, moving its state ranking, which at one point, we're not sure exactly what year, was 49th, near the bottom, to 17th in the state of Kentucky. And that was policy work and lots of amazing work. Anybody here from the Sanford system or who worked with the Sanford system? There you are. Welcome. So one of the largest healthcare systems in the Midwest, and they signed our 80% pledge, and they had a multifaceted approach, and they, across the system, increased screening from 68.7% just in 2015 to 76.3% in 2018. That's a big increase in just a few years, and they had 29 primary care teams achieved or exceeded 80%. So big shout out to Sanford. And you're going to be hearing from, I think, Sanford, Noella, and AT&T during the meeting at breakouts or at panels, so make sure you tune into them. A lot to learn. All right, gang, 2018, that's our final report. Congratulations. Why don't we do one big applause for all of our partners, everyone who committed in 2018. But we've launched something new, and that's 80% in every community. First thing I want to tell you, where's our patron father of 80 by 18 who first suggested the 80% goal, Jim Hott, sitting right up here. Give us a wave, Jim. Jim made the argument at that steering committee meeting in 2013, said 80% should be the number. We can do this, and he was absolutely right. In an insured, older population across the country, you'll hear more data about this later, we can exceed 80%. But the important lesson here is that 80% can even be reached in federally qualified health centers. At least 31 FQHCs across the country, there's probably others, have hit 80%, and many, many more are over 70%. If you do everything that needs to be done, you can hit this 80% number. But as our sizzle reel said at the beginning of the meeting, not everyone is benefiting equally. There are many communities with lower rates, racial and ethnic communities who are lower, low-income communities, rural communities, among others. The thing that I want to emphasize, the theme of this meeting, the theme of this talk, is that 80% in every community is something different. 80 by 18 was a national goal. It permitted averaging of rates across all groups. It was a single number for the nation. 80% is a very different challenge. It's about working to achieve very high colorectal cancer screening rates in every community, regardless of the hurdles that have to be addressed and crossed. So let's talk a bit about charting our course to 80% in every community. As you know, a great number of you were part of this. We reached out to members both in this room, outside this room. We listened, we reflected, we researched, and we have now launched and are sharing our 80% in every community strategic plan. It applies the lessons learned from 80 by 18, but it emphasizes the unique challenges associated with this new campaign. So compared to what we have accomplished, 80% in every community will allow us to sharpen our focus. Where do we have to particularly put our efforts to get screening rates to go up, both in terms of age, geography, affinity groups, nationality, et cetera? It guides communities in developing their own strategic plans. Even more than 80% by 2018, 80% every community demands that communities own this. Communities own this. They will need their own plans on how to reach this. It defines what outcomes are important, and it helps us draw a map of how to get there. And most importantly, the in every community must, to be successful, drive a sense of ownership for this 80% goal. So here are 6 objectives that we've identified to carry into our new campaign. Number 1, pretty self-evident, increase screening in the target groups that have particularly low rates today. Number 2, and you're going to see more about this at this meeting. Believe me, folks, this second one is a big deal. We have to increase percent of those starting screening at the right age. I won't share all the data that you're about to see. Trust me on this. That's a big challenge for us. We're falling short there. 3, we have to increase the percent of all adults who receive a strong recommendation to be screened, and wherever possible, give options, because we know options increase the likelihood of getting screened. Number 4, we spent half an hour at steering committee last night talking about this 4th item, increasing access to quality colonoscopy. And we made a commitment last night that I know you will share, as this particular item remains one of the chief sources of disparities across the nation. We still have FQHCs who don't bother doing FITs. Says, why would I bother? My patients cannot get a colonoscopy. Why would I bother doing a FIT? So this one item remains a huge barrier for us, and we made a commitment last night that we're going to garner resources, really put a deep and focused effort in the next few years on taking on this issue of access to quality colonoscopy. Another big item that really bubbled up in the last few years of 80 by 18, we must increase follow-up colonoscopy after a positive stool test. And I'll talk more about that. And we have to increase community engagement. So let's talk about increasing screening in each age group. Screening lags in younger, I mentioned that, and obviously those without insurance. We're doing better with rural populations. So rural alone may not define the entire barrier, but you saw in the data that there are still minority groups who are lagging behind, although fantastic work in increasing rates in African Americans. 2, we need people to start on time. That means promoting family history taking. Many individuals are unaware of their family history of colorectal cancer, let alone polyps, which is also important. We know that many clinicians don't routinely ask about family history. We know that very few clinicians update family history. They do it the first visit, and that's the last time they ask. We know that the EMRs are cumbersome to use even when the tools are there. They may have the tools, but they're not being used because they're cumbersome. And so as a result, many high-risk individuals are starting screening too late. Part of that is family history. And we also know that colorectal cancer is occurring more frequently in younger people, and this demands a far more deliberate effort to begin screening no later than age 50. We know that, as we talked about last year, ACS recommends screening at 45. The task force is currently updating their guideline. But we all would agree that given the new data, 50 is the oldest age to start, and we're falling far short of that. We went over these data last year showing the rise in colorectal cancer incidence among people under age 50, both men and women, 51% increase since 1994. These numbers in the boxes are number of cases per 100,000, particularly a dramatic increase in the risk of rectal cancer, also in distal cancer. This is the annual percentage increase since 1994. You'll see how large it is in rectal, also in distal and in proximal, but less so. Unfortunately, we don't like disparities, but we don't like eliminating disparities by taking rates up to match the higher risk group. And that's what we've seen, is that the risks in whites went up to match the rates in blacks. So we don't see a white-black disparity anymore in this younger age group. It's not the right way to eliminate a disparity, but it does mean that there should not be a white-black difference in terms of emphasizing early age to start. So all tests are equally appropriate screening options. The best test is the one that gets done, right? So, and we know how important choice is. Both the task force and the ACS guidelines recommend that everyone be offered a choice of screening options, because when offered a choice, they're more likely to be screened. That's the bottom line. With choice, they're more likely to do something. A person is more likely to do something. The logical choice, where it's available, is kind of the extremes of invasiveness and cost, colonoscopy versus FIT. But any of the tests are good, very reasonable choices and can be offered as long as they're available in high quality. And offering choice increases uptake. I mentioned insufficient access, and we've had some great solutions that we've looked at in 80 by 18, our links of care model, GI champions, aligning hospital community benefit requirements with donated lower cost colonoscopy. We've looked at other solutions, increasing GI Medicaid reimbursement rates for colonoscopy. It wouldn't just be GI. Fund state CRC screening programs, et cetera. But as I said earlier, this is a problem we really need to tackle. Number 5, increasing follow-up colonoscopy. Lack of follow-up colonoscopy is, after an abnormal initial screen, is a tragedy. So people completing a FIT or DNA stool test are considered to have been screened. And we should not be naive when we see these great numbers that we all celebrated. But remember that in those numbers are people who had an abnormal initial test, who did not get a follow-up colonoscopy. And we're not ultimately about higher screening rates, we're ultimately about reducing mortality. So we really have to commit to this one in 80% in every community. It's a big goal. And that means good education for the patients. It means really good education for clinical teams. But like everything, it demands systemic solutions, tracking, reminders, and tools, and we need to take that one on. Just to give you some idea of how it impacts mortality, recent research from Kaiser Permanente found the risk of colorectal cancer increased significantly when colonoscopy was delayed by more than 9 months, positing a fecal screening test. So it doesn't have to be done perhaps in the next week, 2 weeks, 3 weeks, or even a month, but it has to be done, and it has to be done ideally within the first 6 months. And finally, increasing community engagement. So this is just a picture of one program that you're going to hear about. Tell me the name again. I wrote it down, but I can't remember. Jamie Thompson. So it's Jamie Thompson, who works with Gloria Coronado. Yeah. It's called Boot Camp Translation, and I think we're doing 2 breakouts, right? It'll be repeated in the breakouts, just talking about how to work. And it's a really cool program that actually asks patients themselves to kind of design their messaging and how they want to be reminded. So it's a true patient-centric approach to tackling this problem. So let me finish and talk with you a little bit about our strategic plan, particularly through the eyes of this organization, what the NCCRT needs to achieve 80% in every community. So I won't read them all 8 here because I'm going to go through them one by one, but these are the 8 steps we need to achieve 80% in every community. So 1, let's unite behind the 80% in every community strategic plan. This is just a terrific document. It's resulted from a lot of work, and what excites me about it, here it is, and I think they're going to get this right at their places, but we're working to make this interactive. It'll be on the web. You can use it, you can find it, you can go and fill out your tools, and we're really excited that we've designed a strategic plan template that is a real action tool, and look forward to everybody working on it. Number 2, take ownership and commit to making an impact in the communities that you serve, that we serve, that your partners serve. That is ultimately what will predict our success or failure, is the degree to which we engage partners around the country. This is going to be the work of thousands and thousands of people. Number 3, and we've all been so gratified that though 80 by 18 ended, nobody has sensed any sense of a loss of urgency, which has been wonderful. Real tribute to you and your partners. But we need to maintain the right level of urgency. There are still, look at that number, 51,000 deaths every year from colorectal cancer. Our work is so far from done. 1 in 3 adults still not screened. 1.5 million survivors living, which is great. It's fantastic. But we want more people to live longer, but we also want fewer people to ever get colorectal cancer. We've got a lot of work in front of us. 4, we must grow, diversify, and recruit non-traditional, including, but not exclusively, faith-based community organizations, businesses, different kinds of community groups, community organizations, people whose affinity may be with a particular aspect of their lives, such as LGBTQ or groups. Whatever, there are many types of communities. Most people feel like they belong to more than one. Most of us I'm a member of this community, I live in this community, and all those communities matter. 5, we need to convene discussion around the emerging challenges and opportunities. Meeting, convening, tackling is what matters. Here's our strategic planning group hard at work. Number 6, we must continue to catalyze regional work. That is ultimately what this takes, right? It's got to be done at the regional level. And increasingly, the degree that our partners can own the work, the better. We have been so grateful to our survivors, our survivorship community, the organizations that represent them. Could the survivors in the room of colorectal cancer please stand up and just let us say a quick thank you to all of you. As I've said about this group before, this is the most selfless group of survivors I've ever seen. So many of these people diagnosed at an age, or their loved one diagnosed at an age where screening would never have been recommended, had no hope of helping them through screening. They need better research, better prevention, and we're committed to that as well. But never for a second have we heard anything but championing the cause of screening for those who are at screening age. And we've shared this, by the way, with our other national roundtable groups, such as our lung cancer survivor group. And there's a lot that our colorectal cancer survivor community can share and help inspire others. But they've been amazing. Could not have done our work without them. Number 8, we have to keep lifting up our inspiring stories of success, such as we heard in our National Achievement Award winners. And ladies and gentlemen, there's a week left for your nominations for our 80 in Every Community National Achievement Awards. And just so you know, you can self-nominate You may be harangued into self-nomination because people who do this work don't like self-nominating. You can nominate somebody else. You can tell us about it and we'll figure out how to get you nominated. What we're interested in is finding amazing work. So if you have any questions, find Emily Bell. She will help you get this done. And as I wrap up the talk this year, let me just say, what is this ultimately about? 80% in every community. It really is an exercise in committing to achieving health equity, eliminating disparities. The work we did in 80 by 18 in this arena was fantastic, but the new focus on achieving equity is sharper, clearer, and at the center of 80% in every community. It is about engaging people from diverse walks of life, people who are tackling life challenges that have nothing to do with colorectal cancer, maybe the last thing on their minds or on their agenda. And yet their families need them, their lives should be longer, they should not be cut short. And that is what this campaign is about, is partnering with, helping every community own this goal. It's 80% in every community because zip code is more important than genetic code. Determinants of health, we all know them, that the health of an individual is chiefly determined by where they live, work, play, pray, and go to school, and the degree to which their community supports healthy living. Will their communities, in 80% in every community, support this aspect of healthy living? I believe we can do it. It means that we need different interventions for different people, for different groups. The same intervention, we already know this, will not work for those who face far more barriers. And we need to disproportionately find the right kind of interventions that move from equality to truly achieving equity. The NCCRT has a rich history of generating timely discussion and action to address disparities in colorectal cancer screening and outcomes. We have a vision for 80% in every community. Everyone across the United States has access to and benefits equally from life-saving, quality colorectal cancer screening. We see such dramatic reductions in colorectal cancer incidence and mortality that it is no longer a leading public health problem. I know that's a vision that each of you share. We have core values, collaboration. We're dedicated to partnership, collective action, and the pooling of resources to achieve our goals, and ultimately to the promotion of health equity. We will work to address persistent disparities in colorectal cancer screening rates, incidence, and mortality in priority populations. We have a work that we've done at the American Cancer Society. We've tested this phrase, and everyone we share this with, it resonates, and I think it will resonate with everyone in this room, that no one should be disadvantaged in their fight against cancer because of how much money they make, the color of their skin, their sexual orientation or gender identity, their disability status, or where they live. We did an incredible job in 80 by 18, and we're going to do something even more remarkable for 80% in every community. Thank you very much.